anesthesiologist here at Duke, and I run the syncope side of the clinic, so they asked me to get to talk about syncope. So today we're going to talk about defining what is syncope, understand the etiology, using the diagnostic tools, and then discuss a little bit on management. So syncope is a transient loss of consciousness due to local hypoperfusion, and it's characterized by a rapid onset, short duration, and then spontaneous complete recovery. Syncope is very common. If you look at in the general population per 1,000 patients, as you see here, it's very frequent. And then if you go to a primary care office or you go to the emergency room, you see again that people are coming in all the time for the evaluation of syncope. The age distribution is listed here. It's kind of bimodal. It happens early on when kids are in their 10s and 20s, and then again as you age, once you get 60 and 70, start happening. And if you look at the age from the first frame, again, it increases over time. So even though there's 1 to 2 million patients annually who are evaluated for syncope, the incidence is actually similar in women and men. Some people don't recognize that. 1% of the emergency room encounters with 30 to 40% of those patients being admitted. We spend billions of dollars on this. The quality of life is greatly interrupted when patients have recurrent syncope, and it can cause anxiety, and then just they can't do their normal activities. And then the prognosis for syncope can be very benign, from infrequent episodes like when they're getting venipuncture to other causes of syncope which can be life-threatening, such as ventricular tachyarrhythmias. So when you evaluate people, there's a few questions you want to ask clearly. Is it actually syncope? Did they have transient loss of consciousness that they come back to? Is there a clear etiology? And are there any high-risk features? So did they just fall? Did they trip? That's a question. You know, when someone says, "Oh, I passed out," and then other patients, the older population, say, "Well, I just kind of fell and I tripped." And there's a lot of studies looking at this further, and a lot of the accidental quote-unquote mechanical falls actually are syncope in the elderly. But some people are just clumsy, and so they actually just fall. So it's good for you to figure out and find out from the patient, did you lose consciousness? So how did you feel when you were going down, and then what happened? Was it rapid onset, short duration, and they come back too? Some patients will come in and say, "Oh, I passed out and I was out for an hour." Well, that's usually something else. That's not truly that you're having syncope. It's not transient, it's not rapid onset, and it's not short duration. Was there trauma or was there not trauma? If there wasn't trauma, then trying to differentiate a little bit further. When we think about syncope, the main causes are listed here. There's reflex, or autonomic dysfunction. There's orthostatic, there's arrhythmias, and then there's structural heart disease. And as you see here, the majority fall under reflex, and then the next largest group fall under orthostatics. Cardiac arrhythmias and structural heart disease, thankfully, are low, which are the ones that have higher associated mortality with them. And if you really investigate further, you'll find out about 10% of them have no clear etiology as to why the patient is passing out. So there's a lot of risk scores to help you differentiate. If you have a low-risk patient versus a high-risk, does every syncope patient need to be admitted to the hospital? The answer is no. But if they have high-risk features, then those are the ones that you want to take very serious and you want to get them evaluated quickly. So if their EKG is completely benign, they have no heart failure, they're not short of breath, they're not anemic, and their blood pressure is fine, then that makes them a low-risk patient. If they have any of those features, especially by the San Francisco syncope score, then you probably need to get them evaluated quickly and decide if they need to go into the emergency room to be admitted. As you can see here, there's several different scoring systems that are out there, but the bottom lines for each of them are, is there evidence of structural heart disease? Do they have an abnormal EKG? Were they exercising when they had their syncopal event? And then are they anemic? Are basically the ones that you really want to figure out. There's a risk calculator. If you don't remember which one, you just Google it and you can find in some of these. And if they meet enough of the criteria, then you need to take those patients very seriously and move forward with getting them evaluated quickly. Again, high-risk features, heart failure, MI, higher, those will be listed as a higher risk feature. Did they have their syncope when they were exercising? Were they completely supine when they had their syncope? Do they have palpitations all the time? Do they have a family history of sudden cardiac death? Looking at their EKG, do they have evidence of bundle branch blocks or left anterior fascicular block or posterior fascicular block? Do they have conduction delays that would put them at risk of having pauses, which they may have them have syncope? Do they have evidence of legato on QT or any other things that would be a higher risk patient if you had these as a cause of syncope, putting you at higher risk of having ventricular arrhythmias? And then if they're remarkably anemic, then that could be playing a huge role as to why they're passing out, because their active blood volume is low, and then those would be the ones that you would, again, want to admit and evaluate further. If you look at these patients and their outcomes, if you say if they're a low-risk patient, do they die? Do they do okay? Do they have any serious outcomes? So if they're low, they don't have serious outcomes, and if they are high or medium risk, then they have some serious outcomes. Overall, the serious outcomes number is low, but obviously in the high-risk population, those are the ones that are mostly affected. Another one is if somebody comes to the emergency room, they have this Rhodes rule. So they look at their EKG and they say, are they bradycardic? Are they less than 50 beats per minute? Are they anemic? Do they have chest pain associated with their syncope? Does their EKG show evidence of a Q wave, typically looking for pirate line? And are they hypoxic? So if they have a BNP that's elevated, you're concerned about potentially having heart failure. If they're bradycardic, then you're concerned that they may have conduction disease and have time maybe pause. If they're anemic or if they're having chest pain, then those are the ones, again, that you want to move forward and get those patients evaluated quickly and go ahead and admit them. So there was a trial that was done called the SEES trial out of Mayo. And what they did in this study was look at patients who had come to the emergency room with syncope, and they tried to differentiate whether or not the patients needed to come into the ER versus not. And they had everybody evaluated, and they randomized patients to this short stay, kind of like our cardiac evaluation unit in the emergency room, short stay ER, versus bringing them up to the floor for a full workup. And if they were randomized to this cardiac evaluation room unit, then they could decide, watch them overnight, and then get them seen quickly within the next few days by EP for potentially tilt table testing. So the high-risk people, those all went into the hospital. Those are the ones that we've already talked about. But they put some intermediate-risk people in these units, and then they had the low-risk people. So a lot of the low-risk people, they could go home, and then the intermediate-risk people, they could go to potentially into a CEU observation unit, and then the high-risk people could come in. And what you found was that when you follow these people out, the people who were seen in these short stay units, which are the dark line, are the ones who they did fine. And so you can pick even intermediate risk patients, and you don't have to admit them to the hospital for their evaluation. The dotted lines are the ones who actually were in the hospital. So that you can see what the outcomes are related to how the patients did, depending on their workup and whether or not you actually need to admit the patients. So when I talk to our emergency room, we talk to them and say, you know, if the patient has some risk factors, but they're not extremely high risk, then those patients can get evaluated, and then they can follow up very quickly in clinic for us to figure out what the next steps are. You know, what's been occurring is that a patient comes into the emergency room, and then they all get admitted to the hospital. They all get a head CT, EKG, echo, stress test, and what we found is that that's not cost effective. We're not figuring out the etiology. So I have people refer to me in the CTP Dysautonomia clinic where it's a 24-year-old woman and a 70-year-old man having the exact same workup in the emergency room coming to see me. So they have their carotids and their echo, their stress test, potentially an MRI also, and that we really need to think about how do we risk stratify the patients and figure out what tests are most appropriate for them. So when you evaluate somebody who has syncope, really, you want to get the history. And in my clinic, in the syncope clinic, I spend a lot of time talking to the patient in order to figure out really what happened, what were your symptoms that were occurring, and then from that, get an EKG, and then figure out what else I may need to get. So a lot of patients will come from the emergency room or primary care or somebody who's seeing them and they've had syncope, and it's an automatic cardiology and neurology referral. And if you go back to a few slides when I talk to you, like, what is the true etiology of syncope? You know, syncope is not primarily a neurologic problem. Okay, it's as you talk to Dr. Borglander when he was ahead of neuro here, he said, Camille, if you could just tell people to stop sending the cardiology and neuro referral all at one time. If they have clearly what sounds like a seizure, and then they had syncope in the setting of that, then it seems reasonable in order to get them evaluated. A lot of times it is that they've stopped their heart long enough and then they seize afterwards. But those patients, it's fine for people to go ahead and get them evaluated. But just the automatic knee-jerk referral to both neurology and cardiology, where the majority of syncope would either fall under neurally mediated, which can fall under cardiology, or it can fall under true cardiac structural heart disease problems or arrhythmias. So take your history, spend time on your physical exam, and then figure out what you want to do next. So what are the key things looking for your structural heart disease? Again, looking at your EKG, not just looking at it and say, okay, it looks okay, but looking for what is your QTC? Is there anything suggestive of Brugada? In my clinic, I've diagnosed several patients with long QT that then I sent to Dr. Sun for him to get their genotype. You know, I've had some people who've had very interesting, I have Brugada that's come up because they come in for syncope evaluations. And then, you know, someone missed that there was actually a Brugada out of their EKG. Whether there's underlying coronary artery disease and their risk of ventricular arrhythmias, you know, what is their ejection fraction? How is their heart? Is it structurally normal or not? Do they have palpitations? I agree with Dr. Lewis in saying that sometimes you just put people on a treadmill. You don't have to do a whole bunch of things, but put them on a treadmill and see what happens to their rhythm when they're exercising, and whether or not that reproduces their syncope. Sometimes it's arrhythmias that develop, and then some people will drop their blood pressure the longer that they're exercising. They have neurogenic orthostatic hypotension, and then those patients will then pass out as they're dropping their blood pressure. We want to make sure they're not getting cardiac dilatation and underlying, mixed three vessel disease that's causing it. But obviously, those are the other things to consider. So what is the diagnostic approach? It's a detailed history, physical exam, and EKG. And then after that, you kind of go by what you think from what you found thus far. If you know it certainly sounds like it's reflex syncope, then you can start with just some basic measures in order to support the patient. If you want to evaluate that further, then you can get a tilt table test. Would be something to consider in that. If you're uncertain of the diagnosis and you have more concern, you're going to walk further down this algorithm in order to look for suspected structural heart disease. You can put them on a treadmill like we discussed. You can do EP studies. If their ejection fraction is kind of in between, not terribly low enough to meet criteria for a defibrillator, and they're having syncope, they don't have true scar in their heart when you may have had a cardiac MRI, you may want to bring them to the EP lab and then decide if we need to do an electrophysiology study. Placing a loop monitor. You may want to put different monitors on the patients, and we say whether you decide the patients are having it very frequently or infrequent depends on what type of monitor that you may want to put. Be it a 24-hour or 48-hour Holter, you know the overall yield of those are quite low. But if they're having daily symptoms, then you may be able to capture something that way. Placing a longer external monitor is reasonable. Typically, people would do a 1-month monitoring. And then, of course, we implant these implantable loop recorders, which are very small devices that can stay in for up to 3 years that give us a nice snapshot around the time of their syncope event of what their rhythm is actually doing. Diagnostic tests, the basics start with orthostatics. So every patient who comes into your clinic or ER or wherever for syncope evaluation, then you should start off with getting orthostatics. It's amazing that how much people will talk about someone's syncope, and if you go back through the chart and trying to find out, well, what was their thought process or what did the orthostatics actually show? And so it's important to get that piece of information. And then ask the patient what symptoms they have as you're doing the orthostatics. So if the blood pressure drops more than 20/10, when you're doing the orthostatics from lying seated to standing, then you say, okay, it's a blood pressure thing, or if the heart rate goes up considerably, then maybe it's a heart rate issue, like postural-orthostatic tachycardia syndrome, that may be contributing to some of their symptoms. 3 minutes is kind of the standard what is accepted. Some patients become very symptomatic soon, so get it at the peak when they're having symptoms, and then let them sit down. And make sure you have proper nursing around to support the patient so they're not falling in your office and getting hurt. Carotid sinus. So carotid sinus massages, I do this sometimes in clinics, better probably in a monitored environment. I'm on an EKG, and I'll make sure I listen to the carotids or have looked at all this imaging that they got before they see me, and then we can decide on whether or not they have carotid sinus hypersensitivity. But basically massaging over the carotids and seeing if there's a change in heart rate, do they have a pause, or do they have change in blood pressure, which often means seeing in carotid sinus hypersensitivity. The reduction in blood pressure is 50 millimeters of mercury. And then implantable loop recorders, so there's been several studies. Issue is probably the most, issue 3 is probably the most quoted one. But look at, when patients have syncope, should we be implanting these monitors sooner? And so now, the European guidelines actually have it in the front line. I think we still tend to start with some basic monitoring, like a Holter or an event, and then decide. Technology has evolved nicely, and so the size of the devices are a lot smaller. But we bring these people to the EP lab, and then we can implant these devices. And now, because of the size of it in our hospital-based clinic, we can implant the smaller ones that are now the size of a paper clip underneath the skin. And again, these implantable loop monitors are great because if you think that there's an arrhythmic cause to their syncope, what you can do is you can see what happens. And they can stay in forever, not forever, but for about 3 years, about as longevity is. And it does a snapshot of what the rhythm is around the time of the event. So the patient has a little activated device that they can trigger, and then they can decide on, and then we can get that transmitted to us. And it gives you 7.5 minutes of EKGs around the time of the event in order to truly know what is occurring. And so we found that a lot of patients will actually have pauses on these asystolic events, and then that's really what their cause is. And people who previously had EP studies or had unabridged block or had other things that were being listed here, that really these asystolic or significant bradycardic events may be the cause of their syncope, and then in turn will implant a pacemaker, which then will resolve or improve their symptoms dramatically. So the guidelines in looking at this says that you have syncope and you think that there's no clear etiology that you can figure out yet, maybe implanting these loose monitors sooner may help us figure out. And the overall yield from an ILR compared to a Holter monitor or a 30-day monitor is extremely high compared to those. Tilt table testing, so we'll shift over to kind of dysautonomia or neurally mediated syncope. So patients who have a single episode of syncope with trauma, or patients, if you've already ruled out other high-risk features and you cannot figure out the cause, I think tilt table test is definitely something that we would consider. If they have, if it's a young person and you're not quite sure, you do ultrasounds in the office and you can't figure out exactly what's going on, then it's feasible in order to do a tilt table test. The contraindicated if someone has severe outflow tract obstruction, critical valvular heart disease, or critical cerebral vascular stenosis. Reproducibility and sensitivity are kind of listed here. Depends on different people's hands and how you do your tilt table test. So it's overall pretty good. It's not great, but it's pretty good at giving you an idea of maybe what's happening. When we look at treatment for syncope, you want to aim at the underlying process. If you put a monitor on the patient and they had a pause, you put a pacemaker in them, and that will resolve or improve the syncope. If they had a ventricular arrhythmia, then you treat them with drugs and put a defibrillator in them in order to improve them. And if it falls back into that large group of patients who have some form of dysautonomia, then we always want to start with the basics, okay? Starting with the basics is telling them to hydrate. So many people come into the clinic, syncope clinic, and ask, they'll go through their story, and they drink like 10 Cokes a day and, 1 glass of water, and that's all they get. And so you're using all this caffeine as a diuretic, and, their volume is very ineffective. And so educating people appropriately to drink 2 to 3 liters of water or non-caffeinated drinks is better. Someone who's drinking a lot of alcohol, that's not helping the situation. You may not be passing out from volume depletion, you may be passing out because you're drunk. So I think that that's something that we have to think about. Volume expansion, we do fluids and electrolytes or salt. So the fluids, we get them to hydrate appropriately, the electrolytes, We talk about, the commercially available electrolyte replacements like Gatorade or Powerade, recognizing that they only have 150 to 200 milligrams of sodium in them. And so talking to them about other types of ways to get their salt up, whether they take table salt, as demonstrated here, or using different tablets that have a high sodium content. And then compression stockings. The data, a lot of it came out of about looking at different compression stockings. So 30 to 40 millimeters of mercury up to the thigh is recommended. Abdominal binders probably are actually better than low extremity compression stockings. When you stand, somewhere between 500 to a liter, 500 milliliters to a liter of your volume then is redirected. And so you get a lot of dilatation in your IVC and then further downstream. And so having some of these compression devices may help your venous return related to that. So I always start with the basic saltwater compression. And then after you do those things, then you may want to consider some of these other medications. So fludrocortisone, desmopressin, epogen, all of these are volume expanders. Most people will start with something like fludrocortisone. Vasoconstrictors, vasoactive meds like midodrine or droxidopa are ways in order to constrict the vessels more. Droxidopa is a noradrenaline precursor, which is studied in Parkinson's patients who have MSA, and so those patients will obtain some benefit and decrease the drop in their blood pressure and increase their functional status using droxidopa. Pyridostigmine has been used and studied in some NOH patients, those are orthostatic hypotension patients, or postural orthostatic tachycardia patients. And then using beta blockers like aprepitant, dronedarone for heart rate control, depending on what your other issues are. Having good sleep. So poor sleep leads to syncope. A lot of patients who I see in my Dysautonomia clinic, their sleep is just all over the place, and it's very disjointed. They have ineffective sleep. We've been sending them to one of the psychiatrists, sleep medicine people here at Duke, and just by improving their sleep architecture, having them have more effective sleep, without changing their other medications that we're using, their number of single episodes have decreased. And so that's been an interesting story to see develop. And then looking at exercise training and really postural training and helping these patients learn how to tolerate being upright. And there's some published protocols that are listed here. So in summary, syncope is common. This stratification is very important. If they're high-risk patients, get them in and get them evaluated quickly. If they're intermediate and low-risk, you have time, but they still need to be evaluated. Make sure there's no underlying structural heart disease, and if it is, then address that. Use the appropriate diagnostic tools. We really need to curtail our use of this multiplex of testing that we do in patients who are syncope, and really think about what is most appropriate for the patient that's sitting in front of you, and what are their overall risks associated with these, with the disease process that most likely is occurring. We want to treat the underlying cause and make sure we do that appropriately. And then when you still have syncope, despite all of these things, then consider a multidisciplinary clinic like we have at the Duke Syncope and Dysautonomia in order to help you. Thank you very much.